content, but I mixed some old stuff in there that's on your syllabus that we still got to talk about. So it's kind of mixed in there together. Bye, Miss Cooper. Get out, Miss Cooper. Yeah. Where'd Michelle go?
Maria, maybe the other stuff.
Oh, well, you can let her in when she comes back, if she's back in a minute or two. Because I know the bathroom's a problem. Yes, you're right. That is Maria. That's Michelle over there. Like, y'all look the same. Y'all look the same.
I know they do. They're the same.
Okay, so we're going to talk about strokes. And when you go to the stroke class, you're going to hear about a lot of stuff about strokes. But the stroke class primarily focuses on the initial period. It does talk about some deficits and stuff. So we're going to talk about that briefly because you need to know about it. But the hyperacute stage is in the first 3 to 6 hours. So if you're on the stroke team at the facility you work for, that patient is coming into your ER and you need to know what to do. And that is what they're going to cover a lot, like 5 of your 8 hours are going to be about that on Tuesday when you go. They're going to talk about some of the deficits your patients are going to have and how much it costs the economy and things like that too. So you'll get that. Acute. We're going to talk about the first 1 to 7 days. Where's your patient located during that first 1 to 7 days if they've had a nice stroke? ICU or they go to the floor eventually, PCU. Then subacute, 1 week to 1 month. Where are they then?
The neuro floor.
Yeah.
Or home, depending on.
Depending, yes. They might go to a rehab, usually a rehab. And then your chronic problems greater than 1 month time. Where's that patient usually at?
Nursing home.
A nursing home, or their family's taking care of them. So we're really going to talk about, the beginning part, but we're really going to talk about what we need to do in the hospital, and then what we need to do rehab-wise, and what we need to think about to keep this patient safe and prevent further injury. So that's what we're really going to be talking about in here. Plus covering the stuff on your syllabus, you got to do that. It's my job. That's what they pay me for. That and a million other things. So we're going to talk about this particular patient. She's 79-year-old female. She woke up this morning at 6 o'clock. She complained of a headache to her husband. She had a little bit of trouble saying words. She started drooping. You can see this droop on the side right here. Weakness in her left-handed leg, and her husband took her to the emergency room. Okay? That's our situation. So first thing I want to talk about is the bystander role in stroke management. Because who's going to be teaching the family?
The nurse.
You are. And so they came to the ER with this problem the first time. If you've had a stroke, is there a potential you're going to have another stroke?
Yes.
There is. So you need to tell the family. It's still not normal. You need to call 911. Well, we don't live that far and the ambulance is kind of expensive.
No.
The same with heart tissue. Time is of the essence. If you're
do 100 on the highway.
Yes, if your loved one has a stroke, time is of the essence. So they got to recognize the signs and symptoms of a stroke, and they need to call 911. You don't just put your wife in the car and drag her to the ER. It's not, a gallbladder. It's their brain. So you have to teach people that, though. I'm just going to tell you, my mom and dad live way out in the country, and my dad would put my mom in the truck and take her because he'd never call the ambulance. So, got to teach them how to recognize. This is the mnemonic that they're going to teach you. They may have changed it up a little bit, but this is the one in your book, so I left it on the slide this way. Fast. I'm going to ask the patient to smile, because if they have the facial drooping, that's an indicator that they could have some sort of stroke-like condition going on. Arms. I'm going to have my patient, they're going to actually make you go through this in a sense, each other doing this. I'm going to have my patient to have them raise both arms like this. Then I'm going to have them close their eyes. If there's nothing going on neurologically, they should be able to keep their hands, even with their eyes closed, without moving them. When their eyes close, you're going to see an arm drift if there's a neurological problem. Because when their eyes are open, they can focus and keep them both there. But when you close your eyes, they don't have that control and the arm drifts downward. Speech. You're going to ask them to say certain things to see if they can say it. What was the phrase they gave you?
Can you teach an old dog, or you can't teach an old dog?
Yeah, you can't teach an old dog new tricks, to see if they can say the phrase that you tell them to repeat. Is it slurred? Did it sound right? Are they repeating the words you told them to repeat? And then the T is time. If you observe those 3 signs, or any of those 3 signs, call 911. So you have to teach the family that, because families just don't know. Okay? And the faster I can get you to the hospital, the better treatment you're going to have if I get you to the right facility. Oh, here's the other 2 mnemonics that they put. It's be fast, and the B is for balance. And then E is for a sudden, I don't know how E is this, but it's with the vision and hearing. There's a sudden loss of vision or hearing.
Is that in our book?
I guess ears and eyes. It's not. That's why it's not on the slide.
Okay.
They may tell you that tomorrow, though. But they did just change it recently to be fast, to include balance and ears and eyes. 911. Where do I want my family to take me? I live right in the middle of everything on the Gulf Coast.
The strokes.
Where do I want to go if I have a stroke? Which way? East or west?
East, west. I don't know, that way.
The closest one?
Closest stroke hospital.
Right. If I live in the middle and I have a choice, I want to go to the closest stroke, certified stroke place. That is Memorial. Okay? If I live in the middle and for some reason Memorial's 300 CAT scans are down, I want to go to Singing River. Because when I get there, I want a CAT scan. Because I need to know if my stroke is ischemic and they can treat me, or if my stroke is hemorrhagic and they can't treat me. So, I have this written down because I can never remember this. Singing River Hospital Systems is an acute stroke ready facility. Memorial is a primary stroke center. And the only comprehensive stroke center that we have in Mississippi is in Jackson. So, let's just say I live near Biloxi Regional. Okay? And what's the AMR going to do? They're going to call Merit Health. It's always going to be Biloxi Regional. They're going to call Merit Health because if the CT scan is down, they can't help me. And once I get in their ER, they can't send me away without a bunch of paperwork. Are they cutting into my time?
Right.
So the AMR is going to be aware of who has a CT scan that's open that can take care of this patient because time is of the essence. Our target time is from 3 hours target time, but from the time you get to the hospital door till they start treatment, the goal is 45 minutes. Okay? The national standard is 60 minutes. Memorial's goal is 45 minutes.
Really, they get you in and treated in no less than 10. Lab and CT within 15.
So, when you're in the ambulance on the way, what kind of things do you think they're asking you, or the family in the ambulance?
Last known well time.
Okay? Last known well time. Why is that important?
Because if it's ischemic, then
Your time 0.
That's right. That's like ground zero right there. So if I just woke up and I'm different than I was when I went to bed,
What time did you go to bed?
I'm out of the time frame right there. But if they saw me in the morning and I was normal for me, at 7 o'clock, and then somebody comes at 10 o'clock and I'm not normal, when was my last known time? 7. I'm out of the window. Well, the window really is 4.5 hours.
Yeah.
But 3 is the real window, but 4.5 hours is what they can push it out to. But if the last known time was over that time period, I'm saddled up for treatment, you know.
So it has to be less than 3 is what we're going with? 3 hours?
Your book says 3, but can be pushed out to 4.5. So if your patient's treated within 4.5 hours, that's doable.
So, and then...
No, it doesn't. Do you have book 6 or 9 or 8?
It's a 9.
It says 4.5. If you keep reading in there under the the anti-coagulants, it tells you 4.5. They'll bump it up to 4.5. Yeah. The goal is really 3 hours, though. Okay, they want to know the last time I was normal. What else do you think they might want to know?
Do you have high blood pressure?
Okay, do I have high blood pressure?
Head injury.
History.
So, what's a good way to know what my health history is, real quick? What kind of medications does your mama take? Can you tell a lot of stuff about someone's medications? Oh, I can tell you if you're diabetic. I can tell you if you eat a high-fat diet and have high cholesterol. I can tell you if you have high blood pressure. Oh, you have CHF because you take this Lasix. What if I see on there that they take amiodarone? What can I think of?
Their heart rate.
Heart rate? What am I looking for? How about AFib? Yeah. I can tell a lot of stuff just by getting the list of their medications. So I want to know their health history. Do I want to know if they're diabetic?
Yeah, they're taking metformin and taking sugar.
It doesn't matter. We'll do it. We're going to do it anyway. They'll give you extra fluids and they'll watch for your kidney function. You're still getting that CT scan. This is what I was getting at, though. If I take insulin, what if my grandma, who can't see very well, dialed up 18 units of insulin instead of 8?
That can affect her cognition.
Could that affect her cognition?
Yes.
Could that affect her vision?
Yes.
And her mood? Yeah, because now she has a low blood sugar. So I want to know, are they a diabetic? Do they take insulin? They're going to check your blood sugar. What about alcohol?
Yep.
What's a person who's stupid drunk look like?
Pass out in their car and you gotta
Right.
pull them out.
They're passed out in their car, or they're laying on the street. You don't know what happened to them. So, I mean, sometimes you can smell them and tell. But they're going to check their blood alcohol levels. What about street drugs, particularly cocaine? Can that have an effect?
Yeah.
So, you have to ask those questions. And people usually are pretty forthright and tell you.
Yeah, they
You
are.
know?
I did a lot
They'll
of
tell you.
cocaine.
They know there's two people. They don't want you.
That banana looks good.
Yeah, they'll tell you. So those are some things that you need to think about. What about if your patient has a history of migraines? What do migraines look like?
Her dizzy,
Confusion?
nausea, vomiting.
Nausea, vomiting,
Out
sensitive
of
to
it.
light. Can you have a staggering gait?
Yes.
So you need to rule out if your patient has migraines. And they call those stroke mimics. Okay? You got to rule out all the mimic things that can mimic a stroke. Yes.
So, okay, you said, like, time is very important. So, like, are they doing this in the ambulance on the ride over there? Okay, so they're just trying to figure out real quick, like, what all could be wrong.
How does the ambulance communicate with the ER?
Radio.
Call it in. I'm bringing her in. This is what I know. These are the meds she takes. This is what's going on. And they phone ahead. They let them know that somebody's coming because the minute they walk in the door, things start happening.
Okay.
Okay? So in our little stroke, this is her back history. She has AFib, hypertension that's controlled, and hyperlipidemia. She had a cardiac stress test that's normal. She takes some medications, hormone replacement. People who take hormone replacement, are they increased or decreased risk for strokes? Increased risk of blood clots and strokes. So we know she has that problem. She has blood pressures controlled. What about this?
That's clotting.
Okay, that's clotted. AFib is the number one factor in patients that have strokes. Okay, that was her background. Here's her assessment. I can see some expressive aphasia. She's got that left-sided droop. She's got that left-sided weakness and hemiparesis. So we need to find out a definite diagnosis. We think she had a stroke. Okay? We already got from the ambulance part of her medical history. They've done an assessment. Is the doctor going to do an assessment?
Yes.
Yeah. Then they're going to start doing some diagnostic tests. What kind of tests are they going to do?
CT angio.
CT angio. So, are they going to do labs?
Oh, yeah.
So they're going to do labs the minute you walk in the door. Okay? They do want to check your kidney function because of the contrast. But the gold standard is a CT scan without contrast. So regardless of kidney function, they can still have the CT scan. What other labs might I be interested in knowing?
They're going to get everything. They'll pull
They are going to get everything.
They're gonna check sugar.
Okay, they're going to check blood sugar.
CBC, a CMP,
Okay, what am I looking for in the
Pneumonia.
What am I looking for in the CBC?
the platelets.
Okay, I'm looking for the platelets first because if they're high or low, I need to know that. I'm looking for an infection just to rule it out. Why do I care about H&H?
Perfusion.
Could be a bleed. What does my red blood cells and H&H carry? If I'm bleeding, a big GI bleed, and I'm not carrying enough oxygen to my brain, can I show stroke-like symptoms?
Yes.
So they're looking for that. What are they looking for on a BMP?
How much fluid is on your heart?
Okay, BM. M as in mercy.
Oh, and
M.
To see if your heart is damaged.
no, B.
What's a BM? What is that? I don't even know what that
Basic
is.
metabolic
Basic
panel.
metabolic-
Your electrolytes.
Oh.
Electrolytes.
Your
What am I
sodium
looking?
mainly.
My sodium. I'm looking for the sodium because the sodium affects my cognition. So if my patient has cognitive deficits, is her sodium 122?
Probably.
Because that could be a problem. Is her sodium 152? That could be a problem. What else might I be looking for? What other things?
Yeah.
That can make their muscles flaccid and stuff, but it's really not going to affect the cognition part of it.
Did you look at the potassium? Yeah, your potassium.
Okay, I'm looking at all of those. But what other kind of tests am I going to look at? Do you think I might want to look at a PTINR?
Yes, to know how the body.
Right, because I don't want to do something to do anticoagulation if it's already high or low or something's going on there. So I'm looking at PTINR. Do you think I might want an EKG? Yeah. I want to see the rhythm. I want to see if they're perfusing because my cognition problem could be coming from lack of perfusion. Okay? What about your analysis? Oh yeah, because you got those crazy folks from the nursing home, and you don't know really what's going on with them, and they have a rip roar and UTI, and once you get it fixed with the antibiotic, all that craziness goes away.
Probably want to do a chest X-ray too, to see the pneumonia.
Well, they're not going to do that initially because we need to get the quick things that we can get and get them to CT scan because we've got to get the CT scan before we can start any treatment.
So the number one diagnostic for this is a CT without contrast?
Without contrast.
Okay.
So they're going to get some labs and they're going to ship them off to CT. You think that they're doing this all at the same time? I would never give you a priority question about this because when that person hits the emergency room, it is all hands on deck, and you're starting an IV if they don't have one, or 2 IVs. So you're getting labs, you're getting them prepped to go. Everybody's there working, doing what they need to do. I would never ask you to prioritize because you got 8 people, and whatever their assigned task is, that's their priority. Okay? So I'm going to ask you that. But the test to confirm an ischemic stroke is a CT with no contrast. They're eventually going to check reflexes and all that kind of stuff, but the initial thing is to get them into CT scan. Okay? 45 minutes from the minute they hit the door till we start some form of treatment if it's ischemic stroke. Remember the assessment chapter when they talked about all these reflexes? Just make sure you know what these reflexes, what's normal, what's not normal, things like that. Okay? Put them on there to remind you. We talked about the diagnostic tests. So, we're going to rule out some stuff. Metabolic issues. High blood sugar, low blood sugar, high sodium, low sodium. Those are the big ones that I'm looking for. We're going to rule out seizures. What's your patient like after they had a seizure most of the time?
Delirious.
Very drowsy, very confused.
Yes, they have confusion. They're worn out because seizures are a lot of work. So I want to make sure my patient doesn't have a history of seizures because it could just be that they're post-ictal. Syncope. If my patient has syncope, is that a problem?
Yes.
Yeah. They can stand up and be dizzy and have gait changes because of syncope. Sepsis. There's my UTI person. Or someone who has sepsis in their bloodstream. Are they going to be totally with the program?
No.
Not usually. Usually they're pretty sick. Migraines, we talked about those. Ooh, Bell's palsy.
Yeah.
What is Bell's palsy?
It's facial. It's like, it's just.
It can mimic whatever your like symptoms.
Sure, but it's facial. Right? I know they get facial. Isn't it like mini seizure? It's not a mini seizure.
It's damage to cranial nerve number 5. And it makes the eye droop on that side. And the face droop when they talk, when they smile. They smile just like that lady did. So could she have woke up with some damage to cranial nerve number 5?
Yeah.
Her speech probably slurred because her facial like this. She's smiling in that picture. You can see that the one side was smiling, the other side's drooping. So you got to rule out that it's not Bell's palsy. Is that my primary concern? No. My primary concern is this a stroke? And if it's not, then I'm going to come back and make sure. Drugs and alcohol, that's another big thing that you got to talk to the family about if your patient can't tell you. We talked about all those. So ischemic stroke can be one of two things. A thrombolic stroke is when the clot forms in the blood vessels of the brain themselves. Okay? An embolic stroke is when the blood clot forms because they had a central or a PICC line that got a blood clot, or they had a DVT, and now that clot has moved, and that clot has gone through the cardiovascular system and is now in their brain. This little link right here, I'm not going to play these, but these are actually from the American Heart Association, and they show you an animated thing of what happens with both of those kinds of strokes. So if you want to look at that, you can look at it. So, ischemic stroke, that's what I'm hoping my patient has. Or my patient could have a hemorrhagic stroke. Okay? A hemorrhagic stroke is actually bleeding into the brain tissue. Or an aneurysm, which is what? It's a weakened area of the blood vessel where the blood vessel is ballooned out. What happens if that breaks?
It bleeds.
You bleed into your brain, you have a problem. And then an AV malformation, we're going to talk about that separately. It's something that patients are born with. They don't know they have them until they have a problem with them. And what it is a little tangled up mess of arterial and venous blood vessels. And the blood doesn't know which way to go. And they get a nice big clot right there. So the difference. What's the difference between them? An ischemic stroke has hopefully a decreased blood flow for a shorter period of time because I'm going to do something about it. Okay? They can mimic stroke-like symptoms, either one of them. The symptoms that... Oh, I'm sorry. I'm on the wrong slide. We're talking about TIA. Well, it doesn't make sense. Okay, a TIA. Anybody ever heard someone say, they bring Grandma in and they say, we don't know what's going on with her. She just had one of her spells. Yeah. Grandma probably had a TIA.
Like a little baby stroke.
It's a little baby stroke. And if I have those little baby strokes, they're big precursors, though, for a big stroke. Yes, you've watched Sanford and Son, the big one.
The big daddy.
So, the symptoms don't last long. They have a little slurred speech, then they're back to normal. But they have a little vision problem, and then they're back to normal. Is that something I can ignore?
No.
No, it's not something I can ignore. It's a serious warning sign that a stroke may occur. So I don't want to teach, I want to tell my family. Even if it's not as bad as this stroke was, and you see some changes, you need to bring her back to the emergency room. Okay? So TIAs are on your syllabus, so that's why I threw that slide in there. There's a little paragraph in your book about them.
If somebody does have a TIA, is there something that you can do to prevent the severity of a stroke?
Well, they'll put them on the medications for core measures, which we're going to talk about. Yes, they'll do some hopefully preventive things. You're going to hear when you go to your class, are most strokes preventable?
Yes.
Yes,
I mean,
most strokes are preventable, which is the sad part. They're one of the leading causes of disability in the United States, and most of them are preventable with changing your modifiable risk factors, which we're going to talk about those. Here's one of the risk factors. That really doesn't look like AFib, but that is supposed to be AFib.
Close enough.
That's close enough. It's pretend it's AFib, okay? It's not quite fast enough. It doesn't look like it. But that is one of the biggest contributors to ischemic strokes is AFib, okay? Is AFib treatable?
Yes.
Can I cure AFib?
No.
You can cardiovert them if it's like an incident. But if it's a chronic AFib, they've had AFib for years. Can I control it?
Yes.
Yes, I can control it with antiarrhythmics. I can control it with beta blockers. I can control it with some blood pressure medicines. AFib is a modifiable risk factor. It's the biggest cause of ischemic strokes. Why are we not doing what we're supposed to be doing? You know? People don't like taking blood thinners. People don't like taking the medicines. So that's why we have strokes. So that is the biggest one that she has is the AFib. Here's some modifiable things. You got to know the difference. Not so much for my test and the final exam, but I know Ms. Cooper loves modifiable and non-modifiable risk questions. But you're going to see them on NCLEX, so that's why it's important. If I can change it, it's modifiable. If I can't change it, it's non-modifiable. I can't change that I'm 56 years old. Nothing I can do about it. I really wouldn't want to go back anyway, but I can't change that. I could change that I'm a female. I'm just going to keep that comment to myself. You really can't change your DNA genetic gender, okay? If you are a female and you have female hormones, or if you're a male and you have testosterone, you really can't change your gender just on a whim, okay? It's a whole process. I know, I have a friend who did it. It's a whole process. Can I change my race? No, I can't change that I'm a white female, 56 years old. I can't. Yes, I am. I can't change. Yes, I am. I cannot change if I am an African American and I have a higher risk for high blood pressure. Can I change that? Can I treat my blood pressure?
Yes.
Yes. I cannot change that I am an African American male and I am prone to high blood pressure. Can I change my genetics? Lord, I'd love to sometimes. But you can't change your genetics. If your family history has a family history of cardiac disease, am I at a risk for cardiac disease?
Yes.
So if I'm at a risk for cardiac disease, am I also at a risk for strokes?
Yes.
Yeah.
So I can't change that. Geographic location. I know this is going to sound really stupid because I can change this, but you can't pick up your life and just move because you do know that we live in the stroke belt, right?
Oh, yeah.
Yeah, we live in the stroke belt, the southeast. So I could move to Maine and be out of the stroke belt, but I'm not changing these other things, and I might starve to death because I can't find a job or something. So I listed it as non-modifiable because it's not something you're going to do just on a whim. Modifiable, hypertension. Can I control hypertension?
Yes.
Yes.
If I'm diagnosed with hypertension, am I always going to have hypertension?
No. You can lose it. If you lose weight, you always have it.
I mean,
Change your eating habits.
Exercise. But it's in my chart. I have hypertension. I was diagnosed when I was 22 years old. I've been on blood pressure medicine since then. My weight has fluctuated. I mean,
I guess sometimes I would get rechecked.
it's modifiable because I can treat it. I take my medicine every day, and it's 130 over something. But I'm always going to have hypertension. I can control it, but it's modifiable. We talked about AFib. Can I control coagulation disorders?
no. Well, I mean,
I can control those. People who have sickle cell anemia are at high risk for strokes. I can't change the fact that I have sickle cell, but are there things I can do to not have an episode?
Stay hydrated.
Hydrated, oxygen, not be out in the sun, sweating it all out, things like that. Oral contraception. Okay. There are other ways to prevent having a baby if you're afraid to take oral contraceptives because you're at a higher risk for blood clots and strokes. So that is modifiable. I don't have to take birth control pills. I can use another form. Diabetes. Modifiable? Is type 1 modifiable?
yes.
Yeah, I can control it. I mean, I don't have to have a blood sugar of 300 just because I'm a type 1 diabetic. I can control that by doing what I'm supposed to do with the diet, the exercise, my insulin, monitoring my blood sugar. Lifestyle factors, what are they?
Smoking.
Alcohol.
Smoking. Stop it. Stop it. It's bad for you. If you smoke, it is bad for you.
Everything. If you want to know,
Exercising. Exercising. Do I want my patient to exercise?
Yeah.
Yes. Some physical activity, they say as little as 20 to 30 minutes a day makes a huge difference. What about diet?
yeah.
Diet makes a difference because I can eat a crap or I can eat better stuff. Does economics play a part in this?
Yeah.
It sure does. Because if I have $20, you can guarantee I'm not going to be spending it on fresh fruit and vegetables when I can buy a cart full of ramen noodles and eat for a week. You know what I'm saying? Or what? 20 cheeseburgers. So economics plays a huge part in how. When I was in nursing school, we used to say, she's just non-compliant. She just doesn't do what I want her to do. Are there a lot of things that lead to a patient being non-compliant? Mm-hmm. Knowledge deficit for one. Nobody taught them. Financial for two. There's just a lot of things that go into that affect their lifestyle changes. So, okay, after she had her CT scan, the doctor wrote these orders right here. What do you think is the most important things?
Activates.
CT.
Hmm?
Oh, wait, what?
She had her CT scan already.
Activates.
What do you think?
Obtain a client's weight.
Baseline and her TBA.
Okay, obtain a client's weight. Is that important?
Yes.
Yes. I got to know how much they weigh because this medication that he ordered right here, per protocol, is weight-based. So if I do all this other stuff and I don't know her weight, then I got to stop near her weight, and then I got to do a dosage calculation, and I know how fast y'all are at those. And we only have 45 minutes, okay? So I need her weight first. She probably already had her labs because when they started her IV to do the CT scan and stuff, they probably do the labs. Oxygen. Is oxygen at 2 liters going to hurt her? No. It's not going to hurt her. It'll help. Here's my priority. My priority is getting her weight. My second priority is this, right here. NPO, until a swallowing study is done. You're going to hear them say this on Tuesday 25 times if they say it once. Your patient cannot have anything to eat or drink until the swallow study is done. Because what's the big safety thing? Aspiration. And they say, well, Mama hasn't had anything to drink for 2 hours. Well, she's got IV fluids, and I'm watching to make sure, but she can't have anything to eat or drink. You got to teach the family. You can't give Mama anything either. I'm not just being mean. She can't have anything. Who does the swallow studies? Speech therapy. Nurses will do them at the bedside, but who's truly qualified? Speech.
They'll do a dysphagia screen, but
Right, not the true
Actual
swallow study. Okay, so which one of these can I delegate to my nurse's aide?
just let it fly.
Okay, I can delegate the weight.
B.
I can turn. They can turn
A,
that.
B, E, and C.
Okay.
That manual blood pressure right there.
Okay.
Okay.
Done by the nurse.
Initiated.
No,
When you did your CNA course, did they check you off on vital signs?
they didn't make us do the manual, it's not required.
Yeah, you're supposed to know how to do a manual as a CNA.
Yeah.
Let me go back there. Yes, they can do the weight. They can reposition your patient. Can they put on a cannula?
Yeah.
They can put it on, but they can't start it.
It's considered, oxygen is considered a drug. And under the scope of practice, the certified nursing assistant cannot put the oxygen on. Do they do it? Yes, they do. Can they do neurological checks?
No.
No, but a good technician can come and say to you,
There's a difference.
Sissy, I was just in the room and something's changed with her.
Yeah.
She's not really doing the neurological assessment, but if she is observant and she is a good tech, she's going to let you know that something's going on so you can get in there and do it.
Well, see, I got that test question wrong on the last test, I'm just saying.
What question?
Not exactly what I'm supposed to do.
You can't do
I
you can't do the assessment.
Report that you know there's a change, but you cannot.
And then got a skin breakdown. But they're not doing this.
No, that wasn't my question. That's a mobility question. I've seen that question. So, here's the other thing you need to know about your stroke patient. Just like the Glasgow Coma scale, there's a scale for everything. We are going to use the National Institute of Health Stroke Scale. Okay? It's a score that we give them. On the next slide, I have it broken down a little bit better. They evaluate those 11 areas right there. Speech, the right arm, left arm, right leg, left leg. They do sensory, language, dysarthria. What's dysarthria? Slurred speech. Does that necessarily mean they have some sort of a problem up here? Could be muscles. Okay, so there's a difference between dysphagia and dysarthria. And neglect. Has anybody taken care of a client who had neglect? What do they do?
Well, they definitely don't use that side.
Okay? They don't even recognize that side is there. If I set the tray in front of them and I have left-sided neglect, they're only going to eat what's on the right side of the tray. They're not even going to know the left side is there. So if I have a patient who has neglect and I tell them to use the call light, but I put it on the left side, no. Are they going to even know the call light's there? No. Sometimes, I know.
Oh my God.
They ring it 500 times. But they honestly don't know that that side of the body exists. So,
But to them, they think they understand. So when they do, they're
right. Exactly. Yes.
How was that again? I'm sorry, I missed it.
It's just a neurological disconnect. It is not there. I don't know if they can see it or what. It is not
So
there.
if you stick your hand in the face, they might be able to say like, yeah, I see your hand. Or, I don't know, it's
Yeah.
crazy.
Because we were studying and there was a picture of a man on Google and the shape and half of his face. It was really interesting. So he didn't.
They don't even recognize it's there. I don't know the answer to that. I don't know. But
I guess he like
So if you close their
it's the
right
weirdest
eye,
thing ever.
so weird.
Yeah, it's the weirdest thing ever. And there's, when I approach the patient, if she has right-sided neglect, I don't want to come up on her from this side and surprise her. I want to approach her from the side that she recognizes, And then when she's eating, she eats the right side. I want to turn it around so she'll eat the rest of her meal. It's the weirdest thing. But that's one of the things they assess. You can't really see this. You'll be able to see it when you pull it up on your computer screen. But this is how it's scored. And this gives you a little bit of a description of what the evaluation is. So if I'm doing number 4, facial palsy, I want them to show me their teeth, stick out their tongue, try to move their eyebrows, things like that. It gives you a brief description. And we're not going to look at this video because it's 12 minutes long. But this is a demonstration. The bottom one is a demonstration of a physician actually doing this scale. So if you have time when you're studying, it'll enhance what the scale means if you watch him do the assessment. This site right here gives you a definition of the scoring system, and you can actually slide the little tabs to the right or the left, yes or no, and score a patient with this little website right here. So just look at those when you're studying if you have time. Limb ataxia, they do the finger to the nose, because if I'm off, I might not touch my nose. And then they have them, if they can stand or not, if they're sitting, their heel and run it down the front of their shin. Because they're not going to be able to do that if something's off. It'll be off to the side. I want my client, let me go back one slide. I want my score to be low. The lower the score, the less my deficits are going to be from my stroke. So this is the exact opposite of the Glasgow Coma scale. It also scores from 0 to 42. And you can score a 0, and you can score a 42. But on this one, the lower the score, the better the outcome. Okay? On my ischemic strokes, they cannot even have the TPA, which is the clot buster, if their score is over 25. So I really want their score to be, lower. Cerebral tissue perfusion. That's their problem. They're not getting enough blood to the brain. They've got multiple other problems, but until I restore blood flow to the brain, nothing else matters. Okay? We're going to use fibrinolytic therapy, and we're going to use endovascular surgeries to treat this. Okay? So we're going to talk about those. Let's talk about the drug first. Let me tell you the page numbers that this is on. There's a paragraph and there's 2 boxes, and it's on page 935 and 936, and the chart for best practice for administration is chart 45.5. So Eltaplace is the only FDA-approved drug to give these patients if they had a stroke. The recommendation is 3 hours from time of onset, but if you keep reading in your book, it can go up to 4.5 hours, and they'll tell you that on Tuesday also. So we need to talk about who's eligible to get this drug, how we're going to give this drug, things like that. Think about patient safety. I don't want you to get bogged down in a bunch of numbers. I'll tell you the ones you need to know. Because if I go to Memorial, or if I go to Singing River, there is a national standard protocol that you're going to use. And you're not going to go in the room and say, oh, I know the protocol, I've memorized it. No, that protocol is your orders. So you're going to have it in, they do memorize it, I know that. You're going to have that there because those are your physician orders, and they have everything, they have made it, an idiot can do it. If my patient weighs this, I hit this button, that's how much I give. You don't even have to do dosage calculations. You can be an idiot. It's true. They make stuff idiot-proof for a good reason. Okay, so let's talk about who's eligible to get this. First of all, if Grandpa is over 80 years old, he's already ineligible. You have to be less than 80 years old.
Why?
Because that's the rule. That's the national standard. You're going through the criteria to see if you can get it. First of all, you have to have an ischemic stroke on your CT scan. Not hemorrhagic. Can't be hemorrhagic stroke. Has to be ischemic. Can't be over 80 years old. Next criteria. If your patient takes anticoagulants of any type, warfarin, clopidogrel, Eliquis, any of those, they're ineligible. It doesn't matter what their PTINR is, they can't have it.
And then what's funny is they also give you Plavix while they're giving TPA.
If you had a CT that showed an ischemic stroke that covers 1/3 of your brain that's supplied by one particular artery, the middle cerebral artery, you're ineligible.
Wait, what was that?
If on the CAT scan your stroke is ischemic, so I'm still eligible, but it affects 1/3 of the brain tissue supplied by the cerebral middle artery, I can't have it. Because that artery, if you have a bleed, is the one that's going to kill you. And so you're ineligible. So they look at how much brain tissue is effective. If you scored 25 or higher on that NIHSS, you're also ineligible. You're just moving right over to the no, you can't go. So those are the rules. 25 or higher. And if you have a history of a stroke with diabetes. So if you're a diabetic and you've already had one stroke, you're automatically ineligible. So can you see how your history can rule some of that out? That you already know your patient's a diabetic and they had a stroke 2 years ago? You're already ruled out. Here's some of the things you also need to think about. If my patient has super, super high blood pressure, I'm going to give you the numbers. You don't have to, they're in your book. 185 systolic, and diastolic, one greater than 110, they can't have the TPA until their blood pressure's down. Because if I have all this vascular resistance and the high blood pressure, and now I give you the blood thinner, what's the chance of you bleeding? Increased or decreased?
Increased.
Increased. So they're going to try to bring your blood pressure down, and then they can give it to you. But it still has to be within that. It has to be within this window.
Ms. Geary,
Okay?
so what if you have a history of hypertension? As long as you don't have high blood pressure right then and
Right
there.
then. Right then. You can have hypertension. Do you think that this patient has to have an informed consent?
Yes.
Yes, I gotta have an informed consent because you are giving me a medication that can help me and it can also kill me. So somebody has to give informed consent, even if the patient can't. The dosage. Here's the dosage. They get, you don't need to memorize this number. They get 0.9 milligrams per kilogram. So there could be a math problem. But if there's a math problem on your test, I'll give you that information. The maximum dosage is 90, no matter what your patient weighs. So if your patient's a little skinny thing, they're going to get less. If they weigh 300 pounds, the maximum dose is still 90 milligrams. I do want you to know the maximum dose. The way the medication is given, I calculated my dose, and let's just say we have a big old guy who had a stroke, and his dose is 90. 10% of that is given as one dose as a bolus. And then the 90% is given over the next hour. So who in here has done a heparin drip?
Not done it, ma'am.
Okay, a heparin drip's done the same way. They get a bolus of heparin, and then they get an hourly rate. So this is just a 1 hour dose. So I'm going to give 10% as a bolus, and then the 90% over the next hour.
I saw that on one of my patients' Mars in the hospital when I was confused.
So what kind of things do you think if I'm giving this patient? They've had an ischemic stroke. They're not over 80. They have none of these other things that have excluded them. I start the TPA. I gave the bolus. I started the hourly rate, 1 hour. What kind of things do you think I need to think about? Bleeding. So what am I looking at?
IV site.
Watching their blood pressure and heart rate.
Watching their blood pressure and heart rate. The one thing I'm really looking at, though, is I'm
Making sure
watching
they
their
stay in the
IV
bed.
site. Making sure they stay in the bed so they're safe. And I'm looking at the IV site. Because where are they going to bleed first? I'm going to see it right there as that blood thinner is going in. I want to stop this, though, if all of a sudden they have acute hypertension that they didn't have before. They start complaining of a headache because I'm giving them the blood thinner, and all of a sudden they have a headache. What could be happening?
Pressure.
I now have an hemorrhagic stroke. Or if they start having nausea and vomiting, I want to discontinue. So bleeding, hypertension, nausea and vomiting, or complaints of a headache are the reasons that I would stop the drug.
Why the nausea and vomiting?
Because they're having an adverse reaction to the drug. And what happens when I'm nausea and vomiting to my intracranial pressure? So I have an increased risk of bleeding. Hypertension, nausea, vomiting, a headache, bleeding.
Bleeding at the site, right? At first. You'll see bleeding at the site first.
Probably. So 24 hours later, where might I see bleeding though?
Like bruising
I
or
might see bruising under their skin.
check their stools, urine.
Stool, that's the biggest place I might see it, is when they get up to have a bowel movement. They might call you in the bathroom because I had a bowel movement and the toilet's full of blood. So those are the things you need to. No invasive procedures for 24 hours afterwards, so I really don't want to be putting an NG tube down if I don't have to. You do it before you give the TPA. I don't want to really put a Foley in if I don't have to within the first 24 hours. Most facilities will do a CT scan before they start your anticoagulants, but the new trend is to go ahead and start the clopidogrel while you're getting the TPA. That's the newest trend, so obviously someone did a study and they're changing things. Okay, this is a dosage cal problem. We're not going to do it. but the answer is right there, so you can look at it later. And then we'll talk about the contraindications and stuff when we get back. Okay? We'll answer these questions.